everyone. Lymphoma, nemesis for all pathologists, and especially the WHO classification, because all of us know that the WHO classification of lymphoma is one of the most, it's systematic, but it is very tedious to remember actually. You cannot remember the whole of the classification verbatim as it is there in the current 2017 revised 4th edition. So the purpose of this PowerPoint presentation will be, the way it has been structured will be to give you a backdrop of what the history of classification was, how it evolved to the WHO classification. It will be very briefly mentioned that how we came to the WHO classification blue books, and then it will move on to the categories of NHL, non-Hodgkin's lymphoma and Hodgkin's lymphoma. So in non-Hodgkin's lymphoma, that is where you have to be attentive, that in non-Hodgkin's lymphoma, all the names have been enumerated. But for you as MD, you have to be very, very cautious of the important ones which are important for you as students and as future reporting pathologists. So when the PPT starts rolling, it will start with history and then it will move on to NHL. And in non-Hodgkin's lymphoma, few entities have been marked as I and few entities have been marked as N. So the entities marked as I are the important lymphomas for you in the respective subcategory. The entities marked N are the ones which are newly introduced from 2008 to 2017. We had a 3rd edition in 2008, which evolved to revised 4th edition in 2017. Around 2017 and 18, it was a very hot topic for recent advance also. Now it has become older, but the transition from 2008 to 2017 was an important transition. So the entities marked I are important for you as such to read. This is only for non-Hodgkin's I am talking. And the entities marked N denote that there were some changes from 2008 to 2017. After that, we will have Hodgkin's lymphoma. Hodgkin's lymphoma as a whole is important for you and it is smaller than non-Hodgkin's lymphoma. And as a whole, that topic does not have anything which you can exclude. So it has been mentioned after NHL. And then in the last part of the PPT, before we summarize, there is a very, very recent update of 5th edition WHO, which has been published in Nature June 2022, that is 2 months back. It has mentioned that we are going to have a new edition of WHO, that is the 5th edition, of which only lymphoid neoplasms, the article on lymphoid neoplasms has been published. The article on myeloid is yet to come. So we won't elaborate on 5th edition too much because the blue book is yet to come and the myeloid is yet to come. As it was lymphoid neoplasms which was published and it covers the scope of our PowerPoint, that is why we have mentioned the 5th edition WHO, which was published in June 2022 Nature. Again, it won't be discussed in an elaborate way, but the newer entities in B, T and K and a special category which they have introduced in the update, we'll be touching on that. Then we'll have the summary and then we'll have the references. It is important that you see the references because there will be 3 important articles in the references where you will find elaborate discussion on changes from 2008 to 2017. So now we can have the presentation.
Good afternoon everyone. Topic for today's presentation is lymphoma, WHO classification. So this is the outline. The topics which we will cover in this presentation are mentioned here. First we will see what is lymphoma, need of classification, history of lymphoma classification, WHO classification broad categories, subtype of each of the broad categories, changes from WHO 2018 and then summary and in last references. Coming to the introduction part, so what is lymphoma? Lymphoma are solid tumor arising as discrete tissue masses. These are clonal tumors of mature and immature B cells, T cells, NK cells at various stages of differentiation. These involve primary lymphoid organ like bone marrow and thymus and secondary lymphoid organ like lymph node, spleen and liver. Coming to need for classification. Classification is the language of medicine. Disease must be described and defined before they can be diagnosed and treated. Disease entities should be clearly defined and clinically distinctive. Consensus on terminology and definitions are essential for both clinical practice and research. Coming to the history of lymphoma classification, from 1900 to 1975, there was no particular classification for lymphoma. Some of the important classification which was followed by different countries were American Registry classification, Rappaport classification, and Keele's classification. From 1975 to 1994, many attempts were made to standardize the classification, but nobody was ready to accept a single classification. There was a debate between the basis of the classification should be morphology or functional view. Then in 1994, a group of pathologists sat down and came to a conclusion to make the real classification, that is revised European American lymphoid classification, as the standard classification. Eventually in 1997, it evolved into NHL project. The revised European American lymphoid classification was based on various list of clinico-pathological entities. These were clinical, cell lineage, differentiation, morphological, immunological, genetic, molecular, and clinical information. These are the name of the doctors which sat down and decided on the real classification to be of the standard classification. In 1997, it developed into NHL project. Now coming to the WHO classification, in 2001, first Blue Book of WHO classification was published, which was the second edition. In 2008, second book of WHO was published, which was third edition. And in 2017, which is the recent one, was published in 2017, which was the revised fourth edition. Before going into the details of WHO classification, I will be briefly describing the development of B and T lymphocyte. Coming to the maturation part, the B and T lymphocyte mature in the primary lymphoid organ like bone marrow and thymus, and it activates in the secondary lymphoid organ like lymph node and spleen. This is the schematic diagram of development of B lymphocyte. I will be not going in the details, but I will mention the stages of development, as the lymphoid classification depends on these stages of development. First, stem cell, that is common lymphoid stem cell, it develops into pre-B cell, then to pre-B cell, immature B cell, mature B cell, follicular center B cell, and then immunoblast, and finally into plasma cell. Coming to development of T lymphocyte, prothymocyte is the first cell, then it goes into stage 1 thymocyte, stage 2 thymocyte, stage 3 thymocyte, and eventually it develops into T helper cell or T suppressor or cytotoxic cell. Now coming to the WHO classification 2017, there are mainly two broad categories, that is non-Hodgkin lymphoma and Hodgkin lymphoma. Under non-Hodgkin lymphoma, there are 5 subcategories. The first is precursor B cell lymphoid neoplasm, precursor T cell lymphoid neoplasm, mature B cell neoplasm, mature T and NK cell neoplasm, and plasma cell neoplasm. Under Hodgkin lymphoma, there are 2 main subcategories, that is classical and non-classical type. Under classical type, there is nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depleted, and under non-classical type, there is lymphocyte predominant. Now I will be elaborating the B lymphomas and their subtypes. The first category is precursor B lymphoid neoplasm, and I have highlighted the important lymphomas in green color and the newly added changes in WHO classification 2017 in the blue color. The first subtype is B lymphoblastic lymphoma, NOS, that is not otherwise specified. Here is a picture of BLL which involves tongue. We can see the diffuse proliferation of B lymphoblast in the picture. Second category is B lymphoblastic lymphoma with recurrent genetic abnormalities. The important subtypes are BLL with translocation 922, Q34.1, Q11.2, BCR ABL1. And the second important category is BLL with translocation 1221, P13.2, Q22.1, ETV6, RUNX1. Now coming to the mature B cell neoplasm. Important subcategory are chronic lymphocytic leukemia or small lymphocytic lymphoma, B cell prolymphocytic leukemia, splenic marginal zone lymphoma, hairy cell leukemia. Under splenic B cell lymphoma unclassified, there are 2 subcategories, splenic diffuse red pulse small B cell lymphoma and hairy cell leukemia variant. The new change which is added is there is newly found mutation of MAP2K1 which is found in the new cases of hairy cell leukemia variant. Another important category is extranodal marginal zone lymphoma of mucosa associated lymphoid tissue, that is MALT lymphoma, follicular lymphoma, and the new change is pediatric type follicular lymphoma. The change is in the nomenclature. Previously it was known as pediatric follicular lymphoma and it was included under follicular lymphoma. But now it's a separate entity and it is known as pediatric type follicular lymphoma. Another new entity which is added is large B-cell lymphoma with IRF4 rearrangement. Another important lymphoma is mantle cell lymphoma, diffuse large B-cell lymphoma, that is DLBCL, NOS not otherwise specified. There is a separate entity, EBV positive diffuse large B-cell lymphoma not otherwise specified. The change is in the nomenclature. Previously it was known as EBV positive diffuse large B-cell lymphoma of elderly, and now it is known as NOS, that is not otherwise specified. Continuing with mature B-cell lymphoma, another important entity is HHV8 associated lymphoproliferative disorder. Previously it was known as large B-cell lymphoma arising in HHV8 associated with multicentric Castleman disease. Another important lymphoma is Burkitt lymphoma. Another new entity is Burkitt lymphoma, Burkitt-like lymphoma with 11Q abbreviation, which is a new addition. Then the last important lymphoma of mature B-cell neoplasm is lymphoplasmacytic lymphoma. This is a pictorial representation of the B-cell lymphomas and where it arises from. So from precursor B-cell neoplasm, B lymphoblastic leukemia or lymphoma arises. From pre-germinal center, mantle cell lymphoma arises. From germinal center, follicular, Burkitt, DLBCL, that is diffuse large B-cell lymphoma, and Hodgkin lymphoma arises. And from post-germinal center, marginal zone, mantle lymphoma, lymphoplasmacytic or CLL or SLL or plasma cell myeloma arises. Now coming to the T and NK cell lymphoma. The first category is precursor T NK cell lymphoid neoplasm. The first subcategory is T lymphoblastic lymphoma. Here is a picture of T lymphoblastic lymphoma and we can see the diffuse proliferation of T lymphoblast here. Another category is NK lymphoblastic lymphoma. Coming to mature T NK cell neoplasm, T or NK cell neoplasm, the important category is T cell pro-lymphocytic leukemia. The new entity is T cell large granular lymphocytic leukemia. The change is in this that the newly found mutation of STAT3 and STAT5B are seen in the new cases. There is a new entity, chronic lymphoproliferative disorder of NK cell, which is added. Adult T cell lymphoma, intestinal T cell lymphoma. The new change is that now the newly found cases of intestinal T cell lymphoma are not associated with celiac diseases. Continuing with the mature T or NK cell lymphoma, the important ones are mycosis fungoides, Sézary syndrome, peripheral T cell lymphoma not otherwise specified, angioimmunoblastic T cell lymphoma and other nodal lymphoma of T follicular helper cell origin. The change is that there is a new subcategory of T follicular helper cell. Anaplastic large cell lymphoma ALK positive and anaplastic large cell lymphoma ALK negative. This is a pictorial representation of origin of T or NK cell lymphoma. From precursor cell, T lymphoblastic lymphoma and leukemia arises, and from peripheral or mature T and NK cell, rest of the lymphoma arises. Now coming to plasma cell lymphoma. Although these are included under B cell lymphomas, but I have mentioned it separately since it also contains important subcategories like mu heavy chain disease, plasma cell myeloma, and under plasma cell myeloma variants, there are two important subcategories, moldering plasma cell myeloma, plasma cell leukemia. Monoclonal immunoglobulin deposition disease, and under plasma cell neoplasm with associated paraneoplastic syndrome, POEM syndrome is important. I have already enumerated lymphomas and leukemia of B, T, NK and plasma cells, but these are the list of few chronic important chronic leukemias which are generally missed as these are scattered in the subcategories. So I will be mentioning those important chronic leukemias. Chronic leukemias of B cell type, chronic lymphocytic leukemia, B cell pro-lymphocytic leukemia, Waldenstrom microglobinemia, hairy cell leukemia, plasma cell leukemia, leukemic phase of non-Hodgkin lymphoma, and T cell type includes T cell pro-lymphocytic leukemia, T cell large granular lymphocytic leukemia, adult T cell leukemia or lymphoma, and Sézary syndrome. I have included few pictures of non-Hodgkin lymphomas. I will be explaining these pictures. This is a picture of small lymphocytic leukemia and we can see the effacement of lymph node architecture. In high power view, we can see tumor cells that are lymphocyte, these are lymphocyte and these are the pro-lymphocyte, which prominent nucleoli. This is a picture of SLN including liver and we can see periportal infiltration of lymphocyte in this. Coming to follicular lymphoma, we can see here the nodular aggregates of lymphoma cells that are present throughout the lymph node. These are the nodules. And in the high power view, we can see the centrocytes, which are these smaller cells, and centroblasts, which are these larger cells. This picture is beyond our topic of discussion, but since in last presentation of lymph node, this topic was mentioned, so I am including this picture here. This picture is showing immunohistochemical stain of BCL2, which is generally present in mantle zone in normal lymph node, but here in the case of follicular lymphoma, we can see it in the germinal center. Coming to diffuse large B-cell lymphoma, here we can see neoplastic lymphoid cells. This is a gross specimen of spleen of DLBCL, and we can see the white pulp expansion in this. This is a picture of mantle cell lymphoma, and here we can see the mantle cell expansion, and the germinal center is not even visible. In the high power view, we can see small to intermediate sized lymphocytes here. Coming to hairy cell leukemia, this is a peripheral blood smears. This is a phase contrast microscopy picture, and we can see the hair-like projection from the cytoplasm in this, which is very typical of hairy cell leukemia. And this is a stained picture of peripheral blood smear. We can see the small round blue nucleus with scanty cytoplasm around it and projections from the cytoplasm. Coming to this is anaplastic large B-cell lymphoma. We can see the typical embroid or horseshoe shaped nucleus with abundant cytoplasm in it. And this is the immunohistochemical stain showing ALK fusion protein, which is brown in color. Coming to lymphoplasmacytic lymphoma, it shows the mixture of small lymphoid cells, which are these, and plasma cells, which are slightly larger than the lymphocytes, and these are plasma cells. Coming to the Burkitt lymphoma, it shows in the low power view, we can see the tingible body macrophages, which gives a typical appearance of starry sky, which is very typical of Burkitt lymphoma. And in high power view, we can see the intermediate sized lymphocyte here. Coming to the peripheral T cell lymphoma, we can see here the mixture of small, intermediate and large lymphoid cells. Coming to multiple myeloma, we can see the involvement of skull in this. We can see the punched out lesions which are present on the skulls. This is the bone marrow aspiration of a multiple myeloma patient. We can see plasma cells here which prominent with large nucleus and prominent nucleoli, and we can see cytoplasmic droplets which contains immunoglobulin. Now coming to the Hodgkin's lymphoma. The basis for the classification of Hodgkin lymphoma is immunophenotypic of Reed-Sternberg cells. There are mainly two categories, that is classical type and non-classical type. In classical type, the RS cells are CD15 and CD30 positive and CD20 and CD45 negative. And in non-classical type, RS cells are CD20 and CD45 positive and CD15 and CD30 negative. I have already elaborated the subtypes of this classical and non-classical type. These are the pictures of Hodgkin's lymphoma. The first is nodular sclerosis. We can see a well-defined band of pink acellular collagen which is dividing the tumor in the nodules. Hence, it is known as nodular sclerosis. The second picture is of mixed cellularity. We can see a classical RS cell here, and in the background we can see the reactive cells which contains lymphocyte, eosinophil and macrophages. This is the picture of Hodgkin lymphoma lymphocytic predominant type. We can see popcorn cells over here, popcorn type of RS cell, and in background we can see the numerous lymphocyte. As the scope of topic does not allow me to discuss the details of Hodgkin's lymphoma, but I will be discussing the RS cell and its variant. Coming to the first type of RS cell, that is classical RS cell, we can see here a large cell with a very large nucleus which are mirror image of each other and prominent nucleoli, and a clear halo is present around the nucleoli. Hence, it gives a very typical appearance of R-like. This is classical RS cells are present in mixed cellularity and lymphocyte rich of Hodgkin lymphoma. Coming to the second type, this is lacunar cell. We can see a clear space or lacuna around the RS cell, and hence it is known as lacunar cell type of RS cell, and it is seen in nodular sclerosis of Hodgkin lymphoma. The third type is lymphohistiocytic or popcorn cell. We can see the multilobulated nucleus of RS cell, and it is found in lymphocyte predominant type of Hodgkin lymphoma. And the last variant is pleomorphic variant of RS cell. There can be different size and shape of the nucleus, and it is seen in the lymphocyte depleted of Hodgkin lymphoma. These are the different pictures of RS cell. This is the classical RS cell, this is mononuclear variant, this is lacunar type of RS cell, and this is popcorn type of RS cell. Now the difference between Hodgkin's and non-Hodgkin's lymphoma. Hodgkin lymphoma is mainly derived from B cells, and non-Hodgkin lymphoma is mainly 90% time it is derived from B cell and 10% it is derived from T cells. Nodal involvement is localized in Hodgkin lymphoma. It can spread to the contiguous nodes, and in non-Hodgkin lymphoma it is disseminated. Extranodal involvement is uncommon in Hodgkin lymphoma and common in NHL. Bone marrow involvement is uncommon in Hodgkin lymphoma and common in NHL. Constitutional symptoms is common in Hodgkin lymphoma and uncommon in NHL. The chromosomal defect which we can see in Hodgkin lymphoma are aneuploidy, and in NHL are translocation and deletions. Spillover into the blood is almost never in Hodgkin lymphoma, and in case of NHL it can spread to the blood. Coming to the prognosis, it's better in Hodgkin lymphoma and it's poor in NHL. This is a separate slide of different entity which is known as immunodeficiency associated lymphoproliferative disorders, and the important entities are lymphoma associated with HIV infections, post-transplant lymphoproliferative disorder. Now this is the very recent advance which was mentioned in Nature's and it have raised the issue of 5th WHO classification. There are few new entities which are mentioned in this article, and I have included those new entities in the further slides. These are the new B cell entities which are included in the 5th edition of WHO classification: new plasma cell entities, new T cell entities, and new NK cell entities. A separate mentions should be mentioned for stroma derived neoplasm of lymphoid cell, because previously it was known as histiocyte and dendritic cell derived neoplasm, and these are the newly added entities under this subcategory, that is EBV positive inflammatory follicular dendritic cell sarcoma, myofibroblastic tumor, intranodal palisaded myofibroblastoma, splenic vascular stromatolites tumor, littoral cell angioma, splenic hamartoma, sclerosing angiomatide nodular transformation of the spleen. Now summarizing today's presentation, the lymphoma, what is lymphoma? Lymphoma is clonal chronic lymphoproliferative disorder. It can involve primary or secondary lymphoid organ, and we saw the classification of lymphoma which evolved from 1900 to 2001, and with advent of immunohistochemistry and molecular study, the classification progressed to WHO 2017 4th edition, which is the most recent one. Now 2008 to 2017 in a nutshell: refinement of definition and diagnostic criteria and terminology, introduction of pediatric lymphomas, early and indolent lymphoproliferative disorders, and emphasis on the relevance of phenotypic, genetic, and molecular information and NGS, that is next generation sequencing, for the identification of different entities, and we are eagerly waiting for the arrival of WHO Blue Book for 5th edition. These are my references.